Documentation that supports late effect of a previous cerebrovascular accident, or CVA, codes to Category 438, which 438 really allows for that greater specificity for the residual effect of a stroke. And these are just some conditions that can follow this: speech and language deficits, disturbances of vision, hemiplegia, hemiparesis. And when a patient is diagnosed with both a neurologic deficit from a previous CVA and is also suffering a new CVA, the coder would code both codes, the current CVA and the late effect CVA. When there is only documentation that states the patient has a history of a TIA, transient ischemic attack, or a CVA with no neurologic deficits, the coder is going to code 412.54. Coronary artery disease and angina. So coronary artery disease requires a fifth digit of the coronary artery involved. So the native artery, the artery of a transplanted heart, a bypassed artery. More than not, the coder, when CAD is documented, the coder is going to either code the 41400, which would be required if the patient had a previous history of a CABG, a coronary artery bypass. If there is no documentation of a previous history of a CABG and CAD is documented, the coder is going to choose 414.01. Angina pectoris is chest pain associated with CAD. Of course, you're not going to code angina, stable angina, or unstable angina unless you have that specific documentation from the physician. And stable angina is predictable and consistent. Unstable angina is that chest pain that has changed to a more frequent and more severe form. So you have a greater risk of heart attack with unstable angina. And sequencing of CAD and angina in I9 has always been problematic for coders. But the sequencing of the condition is really dependent on the circumstances of the admission. So patients with CAD often present due to symptoms such as unstable angina. So just one quick scenario: if angina is secondary to CAD, the CAD is sequenced first, followed by the angina. So you can see in these scenarios, CAD is the underlying cause of angina, CAD is going to be primary, and your secondary code is going to be angina. And same with these other two scenarios. In ICD-10, major improvement came with coding of CAD and angina, where coders will no longer have to worry if they need to code angina or CAD first. As in I-10, these are now combo codes. So there's only one code that will include both the CAD and the angina, and if it's unstable or stable. Acute myocardial infarction. So AMI, for correct code assignment, the infarction site hopefully is documented by the physician. And if there is, AMI is also specified by a STEMI, which is an ST segment elevation, or a non-STEMI, non-ST segment elevation. If there is no documentation by the physician stating it's an ST or an non-ST elevation or information regarding that AMI site, the coder should assign 410.9 with that fifth digit depending on the episode of care. So is it unspecified, not documented? Is it the initial episode of care, first time they're being seen for the AMI? Is it subsequent? Are they being seen for an AMI that's been in the last 8 weeks? A big change in I-10, the AMI period changed from 8 weeks to 4 weeks, or 28 days. Non-STEMI and STEMI are included in the titles, and there's a new category to report subsequent AMI that occurs within the 4 weeks of the initial AMI. I included just a diagram here that might be kind of helpful to determine when you code an I-10. Is it a previous AMI? No, you're just going to code the initial AMI. Is it yes? Yes. Is it older than 28 days? Yes, you're going to have an initial and an old AMI. No, you're going to code the subsequent AMI and an initial AMI.